Welcome back to the deep dive. Today, we're really getting into a fascinating medical puzzle. It's pulled from a real-world case study.
hmm
And it highlights something I think many of you find interesting, how patient history, meds, and just, well, careful observation all come together.
Absolutely. These kinds of cases are incredibly instructive.
Our source today is a detailed document. It's called casestudy.pdf. And we're focusing on an 80-year-old woman.
Right.
She went to an outpatient clinic, and her main complaints were pretty serious, severe giddiness, and she'd actually had a few blackouts.
Which is always a concerning sign, especially at that age.
Definitely. Now, this wasn't out of the blue. She was already being treated for angina and hypertension,
Hmm.
and she'd been taking bendroflumethazide, that's 2.5 milligrams once a day, for her high blood pressure for, well, a few years.
So a long-standing medication there.
Exactly. But here's the twist. Her GP, her doctor, had recently started her on nifedipine SR. That's 20 milligrams twice daily
Okay.
because her hypertension wasn't, fully under control.
Right. So in addition to her existing regimen.
Yeah. So our mission really is to unpack all of this. What could be going on? What are the critical clues here?
It's often about connecting the dots, isn't it? The existing conditions, the chronic meds, the new medication, especially considering her age.
It feels like a bit of a medical detective story.
It often does. You have these pieces of information, and you need to see how they fit.
So she'd been on the bendroflumethazide, the diuretic, for years. Then they add nifedipine SR. That SR means sustained release, right? So it acts over time.
Correct. It's designed for a smoother, more prolonged effect compared to an immediate release version.
And that's a calcium channel blocker, another type of blood pressure drug.
Yes, a potent one. Works through a different mechanism than the diuretic.
So you've got two different drugs, both aiming to lower blood pressure, introduced fairly close together, relatively speaking.
And that's immediately where you start thinking about potential additive effects. Two agents working together might lower pressure more than anticipated,
Especially in an 80-year-old.
especially in an 80-year-old. Their physiological responses can be, let's say, different, sometimes less predictable than in younger individuals.
So we have her age, her heart conditions, the long-term diuretic, this new sustained release drug added, and then the giddiness and blackout start.
Correct. That timing is often crucial.
So what was the key? What was the finding that really kind of cracked the case open and explained these symptoms?
This is where that meticulous clinical observation you mentioned earlier comes in. It wasn't a complex scan or an obscure lab test.
Okay.
The most significant finding came from measuring her blood pressure, but specifically how it was measured.
How so?
When she's lying down, supine, her blood pressure was actually pretty good, 120/70.
Or 1270. Yeah, that sounds fine.
All right.
Yeah.
But the crucial part was what happened when she stood up.
Oh,
Her blood pressure dropped significantly, down to 90/60.
wow. From 120 systolic down to 90 just by standing. That's quite a drop.
It is a very significant drop. And that phenomenon, that specific finding, has a name. It's called orthostatic hypotension, or postural hypotension.
Orthostatic hypotension. Okay. And that directly explains the giddiness and blackouts.
Directly. When you stand up, gravity pulls blood downwards. Normally, your body instantly compensates. Heart rate increases slightly. Blood vessels constrict to keep enough blood flowing to the brain.
Right, so you don't get lightheaded.
Exactly. But if that compensation fails or is insufficient, blood pressure to the brain drops temporarily. That causes the giddiness, the lightheadedness, and in severe cases like hers, actual blackouts or scepia.
And why would her body suddenly fail to compensate like that? Is it the age? The meds?
It's likely a combination, heavily influenced by the medications in this context. As we age, the autonomic nervous system, the system controlling these automatic adjustments, can become a bit less responsive.
Okay, makes sense.
So her baseline ability to compensate might already be slightly reduced just due to age. Then you add two medications that lower blood pressure.
The bendroflumethazide she was already on and the new nifedipine.
Precisely. Both are working to relax blood vessels or reduce blood volume, making it harder for the body to mount that quick response needed when standing. The nifedipine, being a potent vasodilator added on top of the diuretic, likely tipped the balance.
So the combination, particularly with the addition of the nifedipine SR, pushed her blood pressure down too much, specifically when she stood up.
That's the most plausible explanation, yes. It precipitated this orthostatic hypotension, and it's particularly dangerous in the elderly because a blackout can easily lead to a fall.
Oh, absolutely. Fractures, other injuries.
Exactly, which is why identifying this orthostatic component was so critical.
So the real aha moment here wasn't buried in complex data, but in a careful, basic physical exam finding, comparing lying and standing blood pressure.
You really underscores that, doesn't it? Sometimes the most vital clues are right there, accessible through fundamental clinical skills, meticulous observation.
It's a fantastic reminder. You change one thing, like adding a medication for, a good reason, controlling hypertension, but it can have these knock-on effects elsewhere in the system.
Absolutely. The body is so interconnected. A drug targeting the cardiovascular system impacts postural reflexes, brain perfusion. It's all linked.
It really makes you think how crucial it is to consider the whole patient, their age, their existing meds, and to perform those seemingly simple checks like postural blood pressure. That one reading unlocked the whole puzzle.
It did. And it highlights the importance of reassessing patients after medication changes, especially when new symptoms arise.
So, perhaps something for you listening to reflect on. How often might these crucial clues lie in careful fundamental assessments rather than always reaching for the most complex tests? It's about seeing how the pieces fit together.